So we'll start by asking the easy question, what are you most proud of in terms of your activity-based funding implementation? Do any of you have something you're very proud of? Shuffle, 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 shuffle. I also asked them a question which no one wanted to answer, was what mistakes have you made, but I thought we'd start with an easy one about what you're most proud of. Someone's itching. Rohan.
So we took a conscious choice, having a greenfield site in New South Wales as far as ABF funding was when the national model came in. We took a decision to embrace it wholeheartedly. We did that, and along with that, aligned it to broader health system reforms in the state that entailed devolution and greater authority being given to our local health districts, as we call them in New South Wales. And I think what we're particularly proud of in New South Wales, and pride always comes before a fall, but we have worked very hard at trying to engage with our clinical community about the specifics of ABF and how it might help them to improve clinical outcomes across the state. So we have gone to great lengths to provide huge amounts of training and information to clinicians and managers around the state, and we are now in a state of activity-based management rather than activity-based funding, where we've provided management tools to our system to enable them to effectively benchmark against each other and benchmark nationally.
Rohan, there's a huge number of doctors, even a greater number of nurses that work in the New South Wales health system. What proportion do you think understand the incentives on the networks or districts in which they work?
Look, it's hard to answer that accurately, Stephen. We recently, last week, had the third of our annual health reform symposiums with 800 participants, clinicians and managers from around the state. We've done that each year for the last 3 years, focusing on the funding and purchasing models. There's an old theory that says if you need to change an organisation, you need the square root of the number of people working in the organisation to be on board with that change process. We've got 100,000 odd staff, so I don't know what the square root of 100,000 is, but I have no doubt that we have reached that number of people in terms of the education and the materials we're providing. And we're rolling out to the 60,000 clinicians we have in our state tools based around our activity-based management portal, which will allow them on their iPads, on their iPhones, to have a look at how they compare in their clinical units to all the other clinical departments in the state.
I've seen the portal and it really is quite exciting. Anybody else got anything they're proud of? Kim, you're smiling. That means you've got nothing you're proud of, or you?
Nothing yet.
Nothing yet. Okay, you've had your chance. Nick.
Can everybody hear me? I guess the main thing for us from Queensland.
Are you speaking into the mic?
Yeah, I'm speaking. Yes,
okay.
That's better. I think the main thing from a Queensland perspective is just really the progress we've made over the last 2 to 3 years. When we started the journey back in 2012, we got a new state government in. We were ablaze with publicity that we were one of the most inefficient states. So I think the number of 11.4% inefficient for Queensland will live with me for many a year yet. We had a range of deficits with our local hospitals, and I think it's fair to say over the last 2 to 3 years we've really turned that around. We now perceive ourselves as being efficient as a state in Queensland. Now, unfortunately, you're trying to measure yourself against a moving target that was 2 to 3 years old, so it's quite difficult to say that with any great certainty. We've got HHSs who are in financial balance. We're certainly improving on access. So I think the whole combination of reform, the establishment of HHSs and the real drive to improve efficiency is probably one of the things I'm most proud of.
Good. Any other prouds? Francis.
So probably from Victoria's point of view, starting at a slightly different base where we've already had an activity-based funding model in place, probably the way that Victoria's approached it, as many of you would know, is that this national ABF process has been a Commonwealth state financing arrangement. It's not been an arrangement that we've used to fund health services because we already had a model in place in Victoria. So from our point of view, and many of you will have heard us say previously that national ABF and the national efficient price is just a reference price that allows the Commonwealth to determine its contribution to funding services in Victoria. And so in many ways what we've done is protect services from the ups and downs and the vagaries of having this national ABF system. And so that sounds a bit awkward to say we're proud of actually not implementing it fully in Victoria. But what we would say is that that's actually been helpful for us. We've done some other things while we've kind of protected services from this kind of Commonwealth state financing arrangement. But what we have done is we've cleaned up a bit of our own ABF in our own system, and it's given us some impetus and perhaps some cover to do that. But also, probably perhaps different from Rohan, we've really focused our performance management and our reform on the performance monitoring framework rather than on activity-based management framework. So we actually probably are in a different place. We're taking a different view, which is that it's the sophistication of the performance relationship and the kinds of conversations that we're having with services and broadening that out to be not just about activity, but broader about experience and outcomes and, all of those indicators.
You just didn't want to get into the hot tub, did you?
And I'm clearly ABF is a gender issue, and I'm certainly not getting into a hot tub with anyone.
Okay, any other state territory you want to say? Oh, Charles, you're looking ready.
I'm looking ready. I mean, this is a peculiar question to ask the Commonwealth about how we're implementing activity-based funding. We only own one hospital these days, and the colleague on my left runs it for us. But
thank you for that, by the way.
Very successfully too. Yeah. But I guess what I would say is that I think a great achievement over the last few years has been that it's possible to have this plenary session with quite senior state and territory people here talking about what they've done to implement activity-based funding. I can remember chairing the equivalent session at a case mix conference about 12 years ago. It was in a dark room under the back stairs, and there were about 20 people turned up. I think we've come a long way since then, partly because of the National Health Reform Agreement. And I think the fact that we're still having case mix conferences, we're having activity-based funding extending into areas that it never was before. It was very much an acute care thing. So I think that's something that we can jointly take pride in.
Thanks, Charles. Any other people want to? Barris.
I'll chip in here. We, Western Australia, we don't carry our emotions around too much, so we don't use words like proud and other things, but pardon me?
I'm wearing my Collingwood cufflinks today, and I'm very proud, even though the results aren't as good as they might be.
I think whilst everything is still a work in progress, the things that we thought about in the early stages, because we did a very quick implementation of ABF prior to the national ABF coming to fruition under the health reform. But we had the elements of a performance management framework embedded with that, and also with our annual budgeting process around ABF, we've got a health activity purchasing intentions document, which tends to deal with the intentions of things we need to do. Now, most of those intentions we had in the early days are still intentions, because obviously the work that we've had to do along with the national agenda really has been a moving feast to a large degree. So we're certainly looking forward to some stability around things so that we can actually move on to better and more improved things that underpin a better purchasing arrangement than we currently have. So that's where we
So you've produced a document. You produced a document, and that's really good.
Yes. I mean, we produce one every year.
And you've got intentions. That's even better. Yeah. That's good. Any other pride thingos? You don't have to have them. If you're not proud of anything, that's fine. Good. So I'll move on.
It makes it very easy to answer Grattan Institute criticism. It's useful for that. Whenever there's some dodgy publication coming out from the Grattan Institute
doesn't have criticism. We just have observations and provide opportunities to states to improve. And some of them have $240 million opportunity to improve. Moving on to our next question. Obviously, one of the issues in activity-based funding is it's all very well for you to have 8, 9 bright monkeys sort of running the system, but as Rohan said in his answer, the whole idea is you've got to have engagement, you've got to have people throughout the system who understand what they're doing and so on, which brings us to the issue of management capacity. And there's two sorts of management capacity. One is management capacity issues in the central administration. And when we introduced activity-based funding in Victoria, it was an issue about people in the central part of the department were used to actually meddling in hospitals and trying to get them to let go was an issue. And there are also issues of design and things like that. And there are also management capacity issues in hospital land. So did any of you come across management capacity issues at any point in the system? And if so, what did you do about it? Or is it still a problem or whatever? And I'm going to ask either Michael or Kim or Ian, who haven't said anything yet, to comment on that. Ian.
Look, in the Northern Territory, I think it's a really good question, put in context of the national discussion at the moment around federation, because one of the issues with engaging management at the coalface is the lack of engagement from the true funder, and to put that into the Northern Territory context, the Commonwealth contribution to the Northern Territory in-scope hospital costs is only 20%, and so the true funder being the Treasury, and it has been a real challenge to get the engagement and build the management capacity when there's an underlying scepticism from the clinicians around the commitment of the funder. I guess what you'd call a purchaser provider funder model.
So you're saying that you couldn't get the engagement because there's not enough trust in the system? Or
Exactly.
Yeah. Up there on the question, we also referred to central agencies. I know that we think that the Department of Treasury and Finance, or Department of Treasury and Department of Finance in the Commonwealth, and Department of Premier and Cabinet or Prime Minister and Cabinet are perfect. But there may also be management capacity issues there, so people might like to talk about the problems they've had in engaging with their colleagues in central agencies. Charles, you represent the Department of Prime Minister and Cabinet, and they dance to your tune all the time, I understand. Do the PM&C and Treasury or Finance, do they understand what they've done or what they're doing or what the issues are, do you think?
I think they broadly do. I think Treasury, once our Commonwealth Treasury colleagues engage with something, they do get across it. I think it's fair to say that the agreement which Prime Minister and Cabinet negotiated on behalf of the Commonwealth has a number of features which were not immediately apparent to the people that succeeded the people who negotiated the agreement.
So no one's as perfect as Kevin Rudd says he is.
I don't think anyone could possibly be that, Stephen.
So, Kim.
In terms of capacity, we certainly had issues in the department. We had issues and still have issues in our LHNs. It's a bit strange, I guess, for a state that's been doing it for 19 years. Victoria did, Pip was at the post, they did get in 1 year before us. But we definitely have issues around people who have the really detailed understanding of case mix. And not only just the modelling side of it, but how you might use the data. There is or certainly was before the national program, a dearth of knowledge around patient costing as well. We were going largely through the motions, I think, with case mix for a while there. After probably 10 years of fairly vigorous activity around case mix funding, the next sort of 5 to 6 years were were really just treading water, really, I think, in terms of the case mix. We didn't have any investment in the model. We didn't do a lot of development work. We didn't have a lot of money to invest in. A lot of the people who were around at the time have moved on and done other things, and with very significant budget pressures that we've experienced over the last few years, the focus has been more on trying to work out where to save a few dollars rather than understanding how the funding's derived.
But why, Kim, why didn't you use activity-based funding to drive that efficiency?
I think it was, Stephen, I think it was more just capacity to do it. I think we, you know, with really stringent budgets come stripping out of lots of positions, and a lot of times that's the admin people that first go. So we lost some resources there. We had some changes in management centrally, so it's not a reflection of the CEO or anybody, but we...
It's all gone downhill since Tony's left, is that what you're saying?
It certainly has got better over the last few years since ABF has been around, but there was... you can certainly see why you'd want to do it, but it was just the capacity to be able to do it, I think, was the problem. And
it is one of the things that surprises me. I visited a hospital in South Australia a couple of weeks ago, and they had more or less, as part of the budget cuts, closed down their patient costing unit. And it just strikes me as odd that you could imagine you could run a hospital, a decent-sized hospital, without knowing what the costs of what you do are. But anyway,
yeah,
you know,
I agree. And I think the national program has reinvigorated that in South Australia, and the pennies dropped, and we're now putting all these new positions back into the LHNs to do that sort of work and doing patient costing in a much more structured way. So we picked up the ball, but it did drop off for a while.
Yeah, Michael.
We had a few issues. We always have issues in Tasmania. We specialise in lots of them.
And Victoria funds it too.
I'm sorry if the middle of my sentence interrupted the beginning of yours. We ran into a few issues, in particular with the implementation of not so much ABF, but the system architecture that came with the health reform agreement, in that the health services which had been structurally divisions of the department and over which we had some oversight and control were suddenly independent statutory authorities and very, very keen to assert themselves as such. So that rather than have the discussions around ABF and about case mix and the detail of it, with clinicians, with coders, with costing staff, with people embedded in the health services, we were suddenly having them only with executive level staff, and a couple of those who asserted themselves as experts may not have had the depth of understanding of the detail of ABF that was required. But fortunately, they've recently found a need to spend more time with their families. So hopefully we'll be looking at that. The other problem we had, as Stephen alluded to, was a problem in the central agencies where overnight we instantly grew some experts in ABF who still profess to be experts in ABF, although they don't seem to be able to put the letters NWAU in the right sequence in any conversation. But they do mean well, and they try very, very hard to represent us.
Yeah, there are development opportunities everywhere, Michael. One of the things Michael didn't refer to, which is, I think, an interesting way that Tasmania dealt with some of its issues, is it has three network boards, effectively, but they have a common chair. So there's one chair for all three of the organisations, which forces a level of coordination, in a sense, for that population. That's, I think, quite an innovative approach to dealing with some of the coordination issues in a state that size. Nick?
I guess probably two levels. The first is around the capacity and capability within the HHSs, which I think has grown markedly over the last couple of years. We've done a lot of work around setting up clinical and coding networks, a lot of training and educational sessions. I think the worry from a department perspective is where the actual staff are that are going to come and fill some of the vacancies. So I think I probably underestimated the complexity of the rollout of ABF from a department's perspective. We've had no issues getting approval to go and recruit more staff, but actually being able to find them and actually bring them in place has proved nigh on impossible over the last year or so. So I think trying to grow our own internally is the answer to that one. The other angle, which we probably haven't touched on, is trying to explain this system to the Minister's office. So we've had a delightful time trying to explain IPA funding administrator to start off with, trying to explain that the data is 2 years old and we're adding indexation on and therefore it's not a real comparison of efficiency. Trying to explain funding guarantees and the timing of payments, so you won't actually get your money till the following.
You don't have to worry about explaining funding guarantees.
Well, we did 6 weeks ago because I had to explain why losing a funding guarantee wasn't necessarily a loss of cash, depending on where the activity levels was. So that was a real interesting discussion. So I think the system can be perceived as quite complex, and certainly trying to explain it in simple terms has proved a challenge over the last 6 months.
Other capacity issues, Beres.
Well, I guess our experience with our Department of Treasury has been a little bit different in that, as I said earlier, we'd implemented a version of ABF prior to the IPA implementation, and that came from a request from government. So since that time, there's been, I guess, a different dialogue between the Department of Health and Department of Treasury. Certainly the budget's now set, and if you look at the Western Australian budget papers, if you've really got insomnia, you might want to do that. And it actually references a weighted activity unit that we're budgeted for the year. So there's been a complete move over the last 2 years from a block-funded process to one which has now got a conversation in the budget process around weighted activity units and pricing associated with that. But as Nick has said, it has a very interesting dialogue in terms of the education and the understanding of the complexities around what we're dealing with. So, but it means that things have moved on quite significantly, and the relationship, I think, between Health and Treasury is probably much stronger as a result of that process. Not that it hasn't been interesting at times and continues to be interesting.
I just remind the audience that you have a chance to ask your own questions, and I think the way of doing that is to use the app, and there's a process there to do that. Francis.
I think it's important to remember that a whole lot of things have happened at the same time. So when people talk about some of the capacity or some of the things that they've needed to do in the system, that's been about establishing devolved governance, or it's about establishing activity-based funding, or it's about establishing the financing arrangements through the national pool. And so you've got to unpack some of those things because they've all been, they're all mixed up together. I think that the funding arrangements through the national pool have done national activity-based funding a disservice because it's made it incredibly complex. And so the complexity of the national, the pool and the national ABF have meant it's incredibly complicated at the centre to determine your budget parameters for the year. So, we're reasonably experienced at ABF, but in Victoria, it takes 5 of us in a room, and we're probably the only 5 people in Victoria that actually understand the interactions between all of the funding arrangements. So I think there is a complexity associated with the pool that's made it worse.
But I think that's only a problem for you and your staff, effectively.
Well, because we've protected the services, we've made sure that they didn't have to deal with that translation issue, and that issue will go away in a couple of years when the pool goes. So from our point of view, that's useful. I think you've got to separate it into capabilities at a system level, so in departments and in central agencies, and there's kind of a capability required there. Then there's a capability between health departments and services, because really ABF is just a tool to enable a conversation to occur in using common language. It's really a language that allows you to kind of allocate budgets and report on accountabilities. And that's only a small part of it. Actually, the more interesting part is on the experience and the strategy and the outcomes and a broader conversation. Then there's an issue, I think, within hospitals or within health services, and what are the skills and capabilities required there. And probably my lesson would be, over the last few years in working at ABF, is simplicity is your friend. And that, you can have fantastic technical, fabulous things, but really if I can't understand it and I can't explain it, then I suspect it's not that much use out there in the sector. And so if there's anything that's come out of this for me, it's the simplicity and being able to explain it to, middle management. And then I guess there's another issue of when you talked about every doctor and nurse, how many know about it? Well, how many need to know about the complexities of the ABF system, and how many need to actually get access to some of the data that might be now available by having an ABF system? So I think you've got to pick who needs to know what when, and target the information at the right level. And probably my last point I'd say that I have learnt through this is that some of the symbolism of what you do is important as well as what you actually do. And so for quite a while in Victoria, we've resisted quality pricing or pay for performance, whichever term you want to use, because actually, you know, in my mind, and the feedback we got from services is really, if I'm just going to put $5 million into a pool and allocate it on a particular basis, not many people are going to necessarily understand that. It's actually, is that really going to motivate people to behave in a different way? But actually what I have learnt is, I think, is that the symbolism of being able to say that actually ABF is not the be-all and the end-all, and we are interested in other things. ABF is not what we're aiming for. We're aiming for outcomes, and we're aiming for quality, and we're aiming for a different experience, and we're aiming to shift money to the right spot. That's what we're on about. And if a symbolic act within a very complicated funding system can help advance that cause, then that's a useful thing to do.
I'll just emphasise Francis's comment about simplicity. You can't expect people to respond to incentives they don't understand. So if the funding formula is just too complex, you can't, so keep it simple is, I think, a really important component of that. Rohan, do you want?
Well, I'd say we have a very different perspective in New South Wales on the whole process, I think. There's almost a theme of, oh, well, this was an irritation that we've had to put up with for the last couple of years, but we're all moving on. That isn't our impression of this in New South Wales. Activity-based funding has become the cornerstone of how we manage our system, how we purchase services, how we improve outcomes for patients, and how we provide information transparently to clinicians and managers around the system. When we started this, we did a readiness assessment looking at the capacity of our system to engage in this. That informed the development of appropriate training and development opportunities. And there's been a concerted and coordinated effort over the last 2.5 years to build capacity in our system. We now have junior medical officers designing iPhone apps that allow them to code on ward rounds. There's that level of engagement and enthusiasm for the transparency and the information that activity-based funding provides, where it's been an incredibly positive and exciting process in New South Wales, and it's been well supported by IPA. We've had a very good interaction at a technical and at a strategy and policy level with IPRA, and we think there's enormous value in having a national efficient price that allows appropriate benchmarking. So New South Wales is not going to move away from an activity-based approach to funding and management. It's something that will persist in New South Wales regardless of what the Commonwealth decides to do in 2017. It's the way we're making our health system as good as it can be.
Anybody want to have supplementary or reflect or respond to any of what other people have said? So our next question is about lessons. When I wrote these questions, I had two alternatives here. This was this one: what is the key lesson for other jurisdictions from your activity-based funding implementation? And the other one was, what mistakes did you make in the implementation? Unfortunately, none of them made any mistakes, so we don't have that question. But another way of phrasing it is what is the key lesson that you think other jurisdictions could learn from what you've done? It's sort of like the proud question, but it's really, I want the other side of it. What is a path that you don't recommend other jurisdictions to go down? What was a dead end, or something that you've made a mistake, or you've done something that others could learn from? Francis?
So I think one of the things that I'm disappointed about that we've done in Victoria in the last few years is that we have not progressed some of the more innovative funding model options. So I think ABF is useful in some circumstances, but actually I've talked about this a lot and people are probably sick of me saying it, but it's next generation funding models that we're interested in. And I think that a lot of our strategic effort has gone into kind of, I guess, defending our position and in trying to work out how to work within the new national arrangements. And we have, and certainly we've got a whole lot of work to do in Victoria on development of better funding models. So, you know, we might say the acute sector's vaguely okay, but there's a whole lot outside the acute sector that needs a whole lot of work. And so for me, I think we have thought, well, let's not invent a mental health funding system for ourselves. Let's not invent a subacute funding system ourselves. We'll wait for the national process and participate in the national process. And we've had, I think, unrealistic expectations about how fast we could do that. And that's meant we've had slightly immature models for some things. But regardless, I guess I think that maybe we should, well, from Victoria, what I would say is we need to look a little more internally and think what is a fit-for-purpose funding model for some of the things that we need to do.
I don't understand what you mean by a next generation funding model.
So I think that we're on a pathway to ABF for everything, and I think that's a bit of a problem because I think in some areas ABF is not necessarily going to be the best approach. And so I guess I'm talking at a more detailed level, so capitation arrangements or enrolled groups or chronic disease or different ways of allocating funding to ensure that we cover the costs that do not rely on an activity count. So those are the things that I think we have probably slightly lost the plot on, and that we need to really reinvigorate our efforts to get some of those arrangements in place.
Is it possible to do those sorts of things in a Commonwealth state context where you've got responsibility for hospitals essentially and the Commonwealth's got responsibility for GP land?
Yeah, so that's why it's not been done, I think. It wasn't done in the past. There was a few goes at coordinated care trials, and I think we had a hope that Medicare locals and hospital networks might actually get together and do something. We'll now wait for the new version of Medicare locals to come to see if maybe there's some opportunities for getting some better funding arrangements, but still within the state responsibility. There are a bunch of services that are community-based services that are not primary care, not necessarily Commonwealth responsibility, and we could do a bit of our own work. So instead of saying, well, it's all a bit hopeless because we can never get the Commonwealth primary care funding in the model, actually I think we've still got within our own remit plenty of opportunity to do things that will benefit the system and benefit patients actually, and will maybe shift the funding in the right direction. So I guess, my lesson, and if I was sort of back at the beginning of the process, I would say don't give up on some of the innovative funding reform that you need to do anyway internally. Don't invest all your effort in the national effort. Yes, you've got to invest a whole lot, but actually we should still seed our own reform locally in innovative funding models, because I think that's the reform effort that we're all interested in over the next few years.
Okay. Any other comments? Rohan?
I guess I encourage the call for developing reform initiatives within your local context, and clearly there are different arrangements between different jurisdictions in how parts of the system are funded. I have to say again, in New South Wales, ABF has been one of the mechanisms we've used to drive that innovative funding model. So by understanding the costs of running our business, whatever part of the business we're talking about, it means that we can then potentially make that a business that can be subject to competition, either with other parts of the public sector or the not-for-profit sector or the private sector. And likewise, we're seeing the development of some innovative capitation-based models within our local health districts, where primary care physicians are voluntarily changing their contracts with health services and committing to providing better outcomes under a different funding model. So activity-based funding and the transparency of where we're spending our dollars has been important for us driving some of that funding innovation.
Just 2 or 3 things to add. One, I guess, is around the non-ABF space, and I think we've probably paid insufficient attention to that, similar to Francis, really. We have contracts worth about 11 billion, and about 3.5 of that is non-ABF block funded. Trying to understand the value that we get from that 3.5 billion, what is a efficient service for some of those community areas, and how we identify what is an efficient price for those, I think is probably something that we've neglected over the last couple of years that we're progressing now. I guess the other aspect, and I think Shane was saying today that once you're, I don't know whether it's Shane or Tony, once you're on ABF, you can never move away from ABF. I actually had a request 2 weeks ago to explore population-based funding in Queensland, so I'm not sure how that's going to progress over the next 6 months, but I think the biggest question we've got is at the moment we fund place of treatment rather than place of residence, and I think that's created some perverse incentives. We have a lot of the regional centres perhaps referring more to the tertiaries so that they could actually handle themselves within their own hospitals, and the tertiaries would tell me that they're not accepting patients back. So I think maybe moving to a place of residence funding model in Queensland might be worth exploring over the next couple of years.
Any Beres?
I think that the lesson that we've learnt, and we did plan for this, but is I don't think the investment that you can put into actually embedding activity-based management, you really can get that to occur in a short period of time. We expected that program to be a sort of 3 to 5 year. We're basically in that cycle now, but we believe now that we've probably got another 3 to 5 year program to actually embed it through the organisation. Government is committed in our circumstance to ensuring that that happens. It's high on the government's agenda. And part of that may be to the way that the governance structures in Western Australia are put in place. I mean, the Minister for Health in WA is the board for all Western Australian health still. So we don't have our governing councils, which is the councils for our equivalent of LHNs, are advisory councils. They don't have any powers at this stage. So we've still got work to do around the purchaser-provider split to make the system an embed. So they're issues that I think that if we had truly thought about 3 to 5 years ago, we'd probably be a few years ahead of where we are at the moment.
You're lucky in Western Australia, you've got a health minister who's a doctor and is all the boards as well, so it really keeps the clarity of the relationship, and he doesn't interfere either in any of the, and doesn't get approached by his friends to make silly decisions. That's good. Kim?
I'm not sure about lessons. We related to my comments previously around our level of capacity. I think the main lesson for a jurisdiction's been doing for so long is just keep the model current and relevant going forward. So I think, like Victoria, we've been waiting for the national program to move into other areas apart from acute admitted and enable us to refresh our local model, which is the work is starting to happen, and it makes it a very useful thing, and I ideally hope that it continues. The other bit, which is really more of a challenge, I think, is just at what point and how much effort do you put in engaging with the system. There's no doubt that we'd love to have many more clinicians engaged in the model, clinicians particularly, and also in patient costing, and we've done a lot of work to try and improve our patient costing data with a new central patient costing system and pump some more resources into that, and we've sort of been gearing up for 14-15 for being the year on both patient costing and ABF that we would tackle much more engagement in the system and with education programs and the like. But it's a tricky balance, I think, finding the right time to strike, because people can turn off this stuff pretty quickly if you don't find a hook from which they can get some interest in it and make it relevant to them. So, and we're hoping that patient costing is that hook for a lot of our staff, and we have a lot of work to do. But so that's not really a lesson; it's more of a bit of a challenge, I think.
So, Kim, early in my career, when I had decisions I didn't want to make, there were two strategies that I had. One was to refer to the Public Health Division for comment, and that would deal with it for a couple of years. And the alternative was to say, look, the Commonwealth is just about to do something on this, and so, look, we should wait for the Commonwealth to take some action. And that also had the same effect. So it was really good strategies for avoiding doing things. Charles, do you have any comments?
Well, given that we haven't really been implementing on the ground, I don't know there's any lessons at that level. I mean, I think I share Francis's point that the agreement is incredibly complex. You can think of ways of achieving the same ends from the same policy ends the Commonwealth was after without having some of the complexity that's associated. And I would hope that if we ever in the position of having to do this again, we can remember that and that we can do it a lot more simply.
Exactly.
We were putting up our hand for the last few years saying something like that.
Unfortunately, that was after you signed, not before.
Yes. Anyway, we won't make any comments. But on the other hand, it is fair to say that the agreement did lead to transparency. It did lead to the Commonwealth sharing the risk, and whether it needed to be a 60-page agreement to achieve that is, of course, another matter. Michael, do you have anything to add?
Only at the political level, I would say that you have to be very cautious about overselling ABF. ABF is very well embedded in Tasmania now, and unlike a previous experience in 1999-2000 in Western Australia, we've just had a change of government wherein the incoming minister threw his full support behind the ABF program and identified it as a key tool in restructuring the health system. So that was reassuring. However, that still hasn't got around a Treasury who a previous secretary very flamboyantly committed that ABF would unleash millions of dollars in efficiencies. And every time he said it, and he said it on more than one occasion, all I could think of was Russell Crowe at the beginning of Gladiator saying, "Wait for my signal and unleash efficiencies." And of course, you know, we are still in an educative process. Tasmania might have been, and the Central Department might have been working on ABF for some years, but its presence in the health system has only been since the NHRA. So we're still getting managers, CEOs, clinicians used to the idea that there's a connection between cost, activity and funding. It will be some time before we can use ABF to its full potential to actually get those efficiencies out of the system. And my concern at the overselling that was pitched to the previous government but the current Treasury is that the frustration might overcome them, that we're not as efficient, that we can't produce the level of savings they want in the time that they want to pull them out of the system, and that they might go back to broad-based budgeting, block funding or other tools whereby they can just issue a global budget and say, live in it. So that might be my only real lesson would be not to oversell it.
Not the only area of the health system where the hype to delivery ratio might be a bit of a problem though. You know, you have to go a long way before you get the e-health record hype to delivery ratio levels. Ian, do you have anything to add?
I think it was mentioned earlier by Kim, just for us, one of the lessons we've learnt or are continuing to learn is just the benefit and the importance of the National Hospital Cost Data Collection and having the early clinician involvement in that, in helping to explain the whole ABF environment. And certainly as IPA have stepped up in their efforts with the collection and particularly the QA process, we've starting to see really positive results as far as clinical engagement goes with the whole ABF program.
So I've now got some questions from the audience, and there are all sorts of questions, and trying to choose which one you might go through. But why don't I start with something about how have you made the link between implementation of ABF and improved outcomes and benefits transparent to clinicians, or, you know, how might you have sold these about what the benefits are? And maybe, Rohan, you're the one who's spoken most about that sort of question.
Yeah. So clinicians have wanted information about their practice for decades. When I first came back from overseas as a young gastroenterologist, I spent a large part of my time with our hospital performance unit trying to get data on the clinical performance of different units, and it would be a lengthy process of trying to get, you know, reams of papers that would take weeks or months to get information. The clinicians want information about their practice, and by giving them the tools to access that readily, they fundamentally, through their competitive natures, through their professionalism, they engage in practice improvement. They want to understand why their length of stay is 5 times longer than the hospital down the road for the same DRG, or their costs of hip prosthesis is 6 times that of their competitor hospital not far away. And that information drives practice improvement. We've invested in a clinical champions network. We have quarterly video conferences with 60 plus clinicians around the state who are our clinical champions for ABF. We've had symposiums. We've gone out to all our LHDs and trained them. We've produced toolkits and handbooks for them, and they've then embraced those in further training materials for their own staff. So it's been a constant effort over the last 2.5 years, and it's really bearing fruit within our clinical groups.
Anybody else want to make some comments about that point?
Just 2 comments really. The first, I guess, is around, not specifically ABF, but around purchasing. And we learnt, I think, over the last couple of years that consulting with clinicians is very different to co-production and co-design. So certainly for the year we're just about to enter, instead of actually producing a purchasing framework and then consulting with the clinicians, we actually started with a blank sheet of paper back in November with our clinical senate, and actually got them to identify what would be the things that would drive clinical and cost effectiveness in the system. So I think that co-design aspect is key. We also do what we call quality improvement payments, which are marginal in terms of dollars, I think probably 20 million, but they seem to have engendered considerable change. So one example is around stroke care. We've probably invested 15 million over 3 years to try and get specialist stroke units established. And the proportion of stroke patients now which are seen in those specialised units has probably doubled or tripled over the last couple of years. So I think we've seen some considerable success. Also some failures when we talk about new to review ratios for outpatients, but you learn from these things as you go by.
This question of clinical effectiveness and so on is an important one. One of the questions here was about introductions of new technologies. In what ways is each state and territory evaluating for approval new, brackets usually high-cost technologies, e.g. new drugs, new devices, new clinical processes, in terms of reducing length of stay, preventing readmission or economic savings in the ABF environment, where high unit costs may have paybacks in other ways? So it's really a question about how is the introduction of new technologies evaluated and incorporated into the ABF system at the state level. Does anyone want to make any comments about that? Victoria's got a systematic process.
No, pretty badly actually. So I think that's another area that we've probably dropped the ball on slightly. I guess, before I get into the detail of that, I guess one of the things that I'm hearing is that ABF is seen as a tool to do clinical effectiveness and provide information to clinicians and do a whole bunch of things, which I kind of get a bit perplexed about, because in my mind and the way it operates in Victoria, ABF is the mechanism that the department uses to allocate funding based on activity, and the bluntest of it is that it allows redistribution of funding based on effort, if you think that that effort is actually delivering better outcomes. And so it's a tool that allows us to kind of do that allocation efficiently. In terms of what does it do to improve stroke outcomes or reduce readmissions, well, that to me is not actually the ABF. That's not the ABF people doing that. That's actually a different uses some of the common data that we're using in ABF, but there's a whole world of improvement that is outside the ABF world. So I think sometimes because we are all into public reporting, we're all into transparency, we're all into benchmarking, we're all into devolved governance, we're all into clinician leadership, and we happen to be doing ABF at the same time, we've conflated the two. And I think that's actually relatively important to try and distinguish that, because you can do a whole bunch of that reform effort without doing ABF, and you can do ABF without doing the reform effort. So that's kind of that little speech. If I go back to new technology, I don't think anyone's doing. I don't see anyone in Victoria doing that particularly well. I don't think we're doing it very well at a state level, and really at the kind of how it's actually happening is that it's led by the field. It's led by clinicians and their own local governance arrangements to determine appropriate new technology or introduction of new procedures, and really we do a catch-up in the funding model. I don't think we're leading on that, and I think it's an area that we need to do better at.
Anybody want to add anything on that? One of the questions there, which is I think one of the ones we've answered, is let's say come after the next election, the Turnbull government reaffirms that it's going to get rid of the ABF from 2017 onwards. I think you've all said ABF is now embedded in your processes. I mean, you've said it quite strongly, Rohan. It's obviously is put up your hands if you think the state, brackets as the system manager, close brackets, will continue to use ABF. I think, Nick, you're hinting you might not. What do the other people think? I think, Michael, you said your Treasury might pull the plug.
Oh, I think the Commonwealth's doing something on that, Stephen, but in the interim I've referred it to the Public Health Division for
Nick, you're the one that's saying it's a bit...
I guess it's, I mean, we've had a big push from a number of our HHSs who want to see population-based funding introduced. And I think I'm trying to explore at the moment what they mean by that. Is it actually that they want to see place of residence funding rather than place of treatment? Is that one aspect? Do they want to see population-based funding while still using an ABF system? I'm led to believe, and I don't know whether there's anybody from New Zealand in the audience, that New Zealand, I think, fund their HHSs using a capitation share, and then inter-hospital charging is actually done on an ABF system. So that's something that we're going to try and explore over the next couple of months, really. But from my perspective, I think ABF is certainly the way to go. But as I say, there are different views across the state.
Any other comments on that? So,
well, certainly from my perspective, we have no indication that our government or Treasury would want to move away from the ABF, irrespective of what happens in the discussions with the Commonwealth around the future of the health reform agreement and the current announcements that were in the last Commonwealth budget. So we certainly will be working fairly hard at, as I said before, embedding it further through the organisation as activity-based management. I mean, the ABF is really the funding tool, but all of the other aspects which sit below that, we would expect that we will continue to be working to get into the system as the way of managing our system going forward.
So you're not off the hook, Charles. So I'll read this question verbatim from... What does the Commonwealth think the future of ABF is after 1718? Has another 10 years of development been wasted again? Of course, it's not a loaded question anyway.
So I think we need to be clear that the government has announced a change in indexation from 1718 and a change in who its funding is going to be paid to. It has not made any statements about what the future of ABF is. Certainly our minister, perhaps having been oversold the benefits by someone, but anyway, he has expressed his view that ABF is a good thing, capital G, capital T. So I think the jury is still out on what's going to happen after 1718. In terms of wasting development, I mean, I think we've laboured, people in this room have laboured for many years trying to get development in areas that weren't just acute admitted. It wasn't until we started to get serious about using ABF for funding, that we suddenly had 1,000 flowers bloom in the sort of deserts of outpatient departments and emergency departments and so on. And I think that has been the impetus which has broadened the scope of ABF considerably. And that sort of led me to reflect on something Francis said earlier. Yes, you can have all the clinical improvement activity driven by information without using it for activity-based funding. But unless you have activity-based funding driving that, the data will never be as good as you want it to be.
Does anybody, I mean, there's a question there, which I won't be able to find immediately, which says something along the lines of ABS has increased the focus on health activity and cost data. What are you doing within your jurisdictions to encourage the capture, utilisation, transparency and quality of this data? Does anybody want to respond to that one? Has anybody got a particularly good trick about what they do?
You just have to use the data. So it's
Yeah.
really simple. You just have to use the data and you have to make decisions on it and you have to stick with it, and then people will fix the data.
Anybody disagree or want to add something to that?
That's right. We in implementing the model, used transition grants transparently to our systems, acknowledging that there were, in the first year or two of operation, concerns about the quality of the data. And what we've seen is that because it was, as Francis said, tied to real dollars, LHDs have improved the
Invested
accuracy
in
of the
getting it
data.
right.
Yep.
Anybody else? Any other comments? Nick?
I guess probably a bit flippantly, one of the things I think will improve the counting and coding in Queensland is we're allowing our HHSs to keep efficient growth from next year, so I would imagine that would drive a significant increase in counting and
They'll find
classification.
some efficient growth.
Yep.
Okay. It's a real surprise that organisations respond to financial incentives. Never heard of it before. Any other comments on the quality and stuff data? Now, there's one interesting question here that what incentive is there to reduce the activity we do? And I don't think they mean, you know, you as managers sort of taking the afternoon off. I think they're referring to hospital activity. So, Rohan, you said fiscal...
Well, fiscal reality, where 28% of the state budget, we become 80% of the state budget by the year 2050 on current projections. We know that somewhere between 15 and 30% of all the people sitting in our hospitals could be treated in other settings were services available. We know that 25 to 30% of all pathology and radiology tests ordered in our system are non-contributory in terms of determining patient outcomes. There's an extraordinary opportunity for us to make sure that we're only delivering the right sort of activity, the sort of activity that actually delivers better health outcomes. And the transparency that the ABF provides obviously is a significant driver for that. And I guess there are questions about whether under the previous model there were sufficient drivers to limit the growth in that activity. I think fiscal reality of state budgets and indeed national budgets will drive some of that downward pressure on activity.
Anybody else want to deal with the reduced activity issue or trying to have sensible activity levels?
So capped budgets. So ABF in uncapped environments encourages activity, but ABF in capped budgets is a different matter. And most of us, I suspect, give out way less than most people need, so there's a kind of natural suppression of activity. The experiment in Victoria of block funding for small rural health services, where they had an activity basis, but then really we said we won't recall if you spend your money elsewhere on community-based activities. We've seen a big reduction in hospital activity in those environments. So I think you have to push the decisions further, as closest to the patients as possible, and push the responsibility as far down as you can, and people will come up with sensible decisions. So I think there's another question, which is not just shrinking activity, but it's the redistribution of activity. And this is where can I exchange, outpatient funding for acute patient funding for ED, for mental health. And I think that's kind of one of the interesting things that we do a little bit of in Victoria, but we've probably got opportunities to do more of. but really it's not for the department to do that. I think that's for services to come to us and say, actually, can we trade this $1 million for this amount? And I think in an ABF environment, you can do that because you can get the equal value. So I'll trade $1 million worth of WEIS for $1 million of mental health bed days. That's cool with me.
But you've created a problem for your own back, Francis. I mean, NWALs are fully fungible. You know, there's a single measure. I think it's only Victoria. Is it only Victoria where you've got WEIS is separate from the VAX, which is separate
VAX and Watts and iSnack, no, we've got them all.
You know, you've created those buckets.
Yeah, but you can reverse engineer that to make, you can trade between those currencies. So it is possible to trade.
They need your approval though.
Yeah, they do need our endorsement, and mostly we're pretty relaxed about swapping those. We see the decision for that as resting with the health service rather than resting with us. And the only constraints we might have would be where we've got some responsibility back to Treasury or back to a national partnership agreement, but there's not many of them around now. So, if we were trying to
Yet again, liberated by the good decisions of the 2014 budget.
Absolutely. So I think that trading, so that it's the redistribution that's possible, and I think we need to get better at that, and I think redistribution on advice of local services is the best way to go.
So you're strongly in favour of subsidiarity as a principle in Commonwealth-state relations. Any other comments on all of this? Any other comments on the...
In terms of activity and activity growth, in South Australia we've reduced the growth of activity, simply probably for the reasons that Rohan outlined.
So Kim, is it still true that South Australia has more activity than Victoria?
Per head of population, our utilisation levels are higher than the rest of the country, and so because of budget issues and we've moved into a true phase of commissioning services these days, and it's all about buying the right services. It's around the right utilisation levels. So we have seen a drop off. We were sort of travelling at 2 or 3% growth going back about 3 or 4 years ago. We're probably sitting around about 1% now, and the budgets that we're setting for 14-15 in terms of targets will be lower than what we achieved in 13-14 in terms of actual. So there is an intent to try and reduce activity.
So an actual reduction, not just a reduction in growth?
It's a reduction in overall activity. It's the targets we've set. Now, whether they achieve that or not is another issue.
Any other comments about the issue of reducing activity? We've got a question here which is about clinical costing systems. I'm not sure whether anybody here on the panel has expertise in this, but it's noted that the price weights by DIG to which the national efficient price is applied is based on the average cost by DIG collected for each hospital. Given that each hospital is likely to have different methods of clinical costing, what steps are being taken to standardise the clinical costing across hospitals to ensure that a variance in costs is not due to inconsistent clinical costing allocations? So that's one for James. Wake up, James.
It was James's question.
It was James's question. Oh, yes. James Downey, yeah. So,
he wanted you to promote his work in standardisation of clinical costings.
Yeah. Does anyone want to try and answer that?
Well, I just think, as Tony mentioned earlier today, as the volume of participating hospitals in the HCDC process increases and there's a greater awareness of it, you'll inevitably get improvements in those variances. And we were talking about data earlier. Publish it more and it'll get better.
Yeah. And I think there can be quite significant swings by changes in the cost allocation process, especially between, if you look at the IFRACs and the amount of money allegedly allocated to inpatients versus outpatients versus EDs and so on can significantly shift over time. Was that a waving a hand, Beres?
Oh, I can comment if you like. Certainly within a jurisdiction, you've got better control around getting consistency, etc. So certainly with the implementation of a new costing system and the processes around that are aimed at improved consistency across our health services and thus the hospitals that sit within those in the costing processes. I guess the difficulty we have in one of our discussions with our Treasury is trying to explain the differences between jurisdictions and also the variability about that, because obviously we're at the mercy of the information which is publicly available in terms of trying to explain that. So from my perspective, we are continuing to work on improving our internal consistencies and understanding that, and a lot of it gets back to the point of making more information available to a wider set of people, which actually will improve that. But I think nationally we obviously, James, need some more information around the consistency across jurisdictions.
So this is an opportunity, for example, for a consultancy in the area of looking at the accuracy of different forms of cost allocation. I wonder if the IPA might actually do something like that sometime.
So I guess we've done a few things. We did a strategic review last year. I spoke about it at this conference last year, and we've implemented a number of changes from that. We've done the independent financial review every year for the last 3 years, where we know that the total cost reported reflects what is actually spent in hospitals, and this year they're going further to look at what are the allocation methods used, so how are costs allocated to individual patients. We've rebuilt the QA process for cost data, so now states get back very detailed QA reports of their data, and it highlights early on the $23 records and things like that just can't be right. So there's a whole lot we've done, and we've revamped the cost report, so you can see the consistency's improving, but we're well on the way, but there's a lot more to do, and it's a real partnership. It takes everyone's effort, not just IPA.
Yes, it's not your data, it's their data. There's another question here. This one's not from James Downey, but if any other James Downeys in the audience want to ask questions, it's still an opportunity to ask questions. Are you aware of any areas in your jurisdiction where ABF has seriously missed the mark, or has itself been a barrier to improving patient care? Shuffle, shuffle, shuffle.
There's some challenges around some of the low volume, high cost procedures. So we have a number of, pelvic exenteration, peritonectomies, high cost procedures for which there aren't currently adequate ABF funding mechanisms, and those create challenges in terms of developing the right funding mechanisms for those. I don't think that's the fault of ABF, it's just we haven't caught up with all the necessary costing work we need across all the streams of activity.
Anybody else prepared to tackle that? Rohan's point is right, that one of the problems of low volume is always going to be instability in weights, and one of the instability in weight, even in a state the size of New South Wales, and that then can be significant issue. So we've got one here from a guy called Joe Hockey. I kid you not. But what about shifting activity from secondary to primary? Why would hospitals invest in avoidance while the Commonwealth is funding growth? So, it's the overall design of the National Health Reform Agreement. You're accountable for that, Michael. So,
because the Commonwealth's not funding growth, they're only funding a small part of it, even when they were funding growth.
Small part, 45%.
So the incentive to move things to an alternative setting is twofold. One is because funding is, I think, without exception, capped at a state level, so activity is therefore capped. And for every efficiency that an LHN, or in our case a Tasmanian Health Organisation, can generate, they can actually reap the benefits of that. They can create their own swings and roundabouts, to use one of Stephen's expressions, within the context of the service agreements, or however they're called by state, such that if the activity is being delivered that we want, that the patient outcomes are being reached, if an LHN, in the Tasmanian case anyway, can find a more efficient way of doing that, we actually encourage them to do that. And I think there's someone from THO, there is actually David from THO Northwest is here, They've in fact led the way in Tasmania by effectively contracting out things like cardiac rehab and other services which can be provided cheaper and arguably better in a primary setting as opposed to secondary or tertiary.
Does it still count as a public hospital service?
No, it doesn't, but because of the way that that particular service is funded, it's not in scope anyway, so it's a state-funded service. It's one of the unhappy experiences of the in-scope activity.
Oh dear. Any other comments on that?
I guess not specifically in terms of the primary and community care, but I guess more pertinent to us at this moment is around rural hospitals and the nationally efficient cost model compared to ABF, and there's a distinct incentive to probably try and centralise more care within the ABF facilities, given that you get efficient growth, whereas you are block on the small rural hospitals. And that's a key issue for us. We're trying to move care back into some of these more rural communities, and a lot of the HHSs are telling us there is no financial incentive to do that at this moment. So that would be one of the areas that we try and address for this coming year.
I don't know the 115 pages of the reform agreement off by heart, but I thought the Commonwealth shared in the growth of national efficient cost, the block-funded services as well.
I think it's just indexation, but I might be wrong. If we see a large influx of activity that can be done locally, I'm not sure we get the growth for that in year, but I'm happy to be corrected.
So we pay 45% of the growth in the cost. But I mean, I guess it's up to you to argue to the IPA that if a block-funded hospital gets lots of people coming through the door, then they need to change whether it's block-funded or not.
Yep.
Any other comments? Rohan?
I think it'd be one of the tragedies of the 2014 federal budget if the removal of growth guarantees, if you recall, the state growth guarantee allowed states to invest in hospital avoidance activities and was intended to drive investment in that out-of-hospital care space. And I think it'd be a real tragedy if that was lost as we go forward. Certainly in New South Wales, we see this as a key strategy for ensuring health system sustainability, but also best patient outcomes. And we think it makes no sense at all to just funnel people into the most expensive parts of the healthcare system, which is the hospitals, particularly when, for many people, the better outcomes would be provided if they were treated in the community. And it's a feature facing all health systems around the world, the need to invest in the right sort of integration or coordination between the different parts of the health system.
But isn't the hospital avoidance activity counted as a public hospital service?
Well, it is potentially if it's designed in the right way, but there was additional investment under the agreement associated with the state guarantee specifically around that activity that will no longer exist.
Okay, any other comments on this one? There's another question, not from James Downey. This is Cathy Shane's presentation raised the importance of integrated and coordinated services to improve care and reduce costs. Under the National Health Reform arrangements, the Commonwealth had skin in the debate with regards hospital costs with its exposure to activity growth. This gave some confidence that the Commonwealth may invest wisely in community-based services, or invest at all, I think they mean. Activity-based funding without a National Health Reform agreement effectively uncouples the program and removes access to key reform options. It will impede the changes emphasised in the National Health and Hospital Reform Commission report, an excellent report, by the way, if you're interested. What now? We have a pregnant pause while the Commonwealth thinks, 2 years minimum. Well, let's ignore the last part, but let's go back to the issue. The issue that's being raised here is the integrated and coordinated services and so on. And to some extent, is an activity-based funding orthogonal to that, and how do we deal with that issue of integration and coordination across settings? You hinted a bit at this earlier, Francis, and I think Rohan did. Does anybody want to make any comments or address that question?
I mean, I think as long as we've got two levels of government, two spheres of government funding different aspects of the same thing, we're always going to have problems making sure that people progress through the different funded bits in a sensible and logical way. I don't know that activity-based funding was going to make it any better, and I don't know taking it away is going to make it any harder. So all I can say is wait for the pregnant pause while the white paper on federation comes out and clarifies everything for us.
So the white paper on federation is due at the end of 2015, so that's only 18 months. There's a green paper on the federation in the first half of 2015 and issues papers on health sometime before that. So we may not have to wait quite as long. Francis, you were...
So, I mean, I think that we all bought into this whole national health reform deal with the idea that we'll go through all this agony because the Commonwealth contribution will now be, they will have some skin in the game and they will be exposed to some of the growth risk. And if they're exposed to the growth risk, they might go, well, I can put, a couple of billion into hospitals, or I could reform in primary care, and that would mean I don't have to put a couple of billion into hospitals because I'm doing it cheaply or more efficiently, or I get better outcomes in primary care. So that was the theory. So that has been decoupled, and that is a bit of a problem for us all. And I think we are waiting for the next version of primary care reform and what a PHN's primary health network's going to do, and is that the new opportunity, and is there going to be anything more in that can be substantive that we can deal with? But I don't hold much faith. I think we have got an absence of we don't have any idea of what's going to happen in that space in terms of how the Commonwealth's going to deal with reform of primary care. So I feel a little bit despairing about that aspect of it, and so that's where I'm saying, well, I think we have to focus on making sure that we can do what we can within our jurisdictions, and we have to be very careful that the diversion and substitution activities that we get involved in the state can still be described as hospital services for the next couple of years, so we get our appropriate funding. But, I always worry about the net widening in the state. So I always worry that yes, of course I could invest a lot more in primary care, and that would be great, but that's a very wide, angle to get into. And when I'm busy funding primary care or residential aged care or cross-subsidising for those areas, then how much am I still able to respond to the demand for hospital services? So I think it's quite tricky, and I think it is a bit... That was one aspect of the NHRA that was kind of hopeful and had a bit of vision that actually the Commonwealth will bear the brunt of poor primary care reform, and so we were hopeful that would happen. So yeah, I think it's I can't wait to see what they're going to do next.
I don't know why you referred to the negotiations on the National Health Reform Agreement as agony. I mean, I thought Commonwealth-state relationships were a way of people having fun, and people took leave to actually engage themselves in Commonwealth-state negotiations instead of going to Disneyland.
Well, it is a national sport. I get that. I don't know that the negotiations were that agonising. I wasn't there for them, but certainly the implementation of them has been.
I think there are comparisons to Disneyland, particularly the Pirates of the Caribbean ride.
But coming back to this issue, I mean, it is really a serious issue with the increased incidence of chronic disease, the importance of continuity of care, the importance of strengthening primary care to reduce demand on hospitals, all of that sort of stuff. What do you think? What do people think are the prospects of that, and what can we do, or how does the reform goes forward in addressing those sorts of issues?
So we're going to continue our trajectory and investment in what we're calling integrated care in New South Wales. We think, based on our analysis of how we can maintain a sustainable funding system for our hospitals, we have to improve our ability to treat people outside hospitals. And so the New South Wales government announced a $120 million investment over 4 years in integrated care that is funding large system demonstrators in 3 of our local health districts that are fundamentally changing the dynamics of funding, governance models, service delivery around care outside hospitals. So we will continue to do that. We think it's the appropriate way to deliver the best possible healthcare for people who actually don't want to spend their lives in hospitals, and if we could come up with effective ways of treating them outside hospitals, that'd be good. We're trying to convince the Commonwealth that the smartest way to implement their primary healthcare networks is to align them geographically with our 15 local health districts, because then you can get sensible planning of both secondary and hospital services and primary care services. And we would love the Commonwealth to take a long-term view of healthcare delivery to make sure that the primary health reforms actually can deliver better outcomes rather than a predetermined number of primary health networks.
Any other comments on this issue? And it's one of the issues that health systems around the world are struggling with, and not necessarily done very well around the world for that matter. I'd like you to thank both yourselves for the questions you've asked and the panel for the answers they've given. So thank you very much.